Hello, everyone. A very good evening to all of you. I am Dr. Sandeep Sharma, your pediatric super specialty faculty at PrepLadder, and welcome you to this unique series of sessions on YouTube. We are calling it as Last Resort Revision. When you are, at in a doldrum or at crossroads regarding how to compile all those one-liners and PYQs together related to super specialty, this is our endeavor at PrepLadder SS to give you that in a brief format. Let me tell you what we are going to do. First of all, I hope I'm audible and visible. You can comment in the live chat also. I've put my phone also, my own face I'm seeing right now as I'm talking to you. Uh, but at the same time, I will not be looking at the comments. Reason being, because I have to teach you, we have to cover a lot of ground in the limited possible time. So once I'm done with the topics, I will be making it an open house. All the suggestions, all the queries, whatever you have regarding super specialty preparation or regarding the topics that we are discussing, you are most welcome to ask me in that, right? But for me, for now, just join me. Let me give you. I'm right now having that feeling like whenever you are doing your residency and you have done a 36 hours duty and still you have to do a presentation in the morning. I know that. Do you know that feeling? I'm having that feeling right now. So I'm a bit jet lagged. I was out of India. I've just landed, just reached home, barely reached home, turned on the screen, and I'm taking this interview right now as I'm talking to you. Today, I'm focusing on nutrition part. Particularly, I'm going to focus on severe acute malnutrition, including the NEET SS questions in 2021, 2022. I will also be focusing on obesity, the changes which have happened. Because the current video, which is available on the app also, we have made some changes in that, but there have been some recent changes and recent recommendations related to obesity in children. It's a hot topic from where questions are expected. So I am going to take up in details. Apart from that, I will also be talking about the malnutrition part. I'll be talking about rickets. I'll be talking about vitamin A, and I'll be talking about the fat-soluble vitamins. Regarding the metabolic disorders and four of the systems, we will be taking in a longer session in the part two video, and then part three and four will be coming subsequently. So let me start with the session without wasting any time. So what to expect in this LRR? Rapid review of most important one-liners we'll be doing. Topics asked in SS 2018 to 23 have been included where possible. Additional highlighted points I have added here. Rare topics which are not discussed in regular videos but otherwise asked I have included. So when we discuss metabolic disorders in LRR2, I will be talking about methylmalonic acidemia, on which question was asked in INISS recently. I will be talking about peroxisomal disorders, which I have not discussed in a regular video. So based upon your recommendation, I'm taking them up in the LRR itself. So don't miss this LRR, even if you are a regular PrepLadder SS subscriber. And if you are not a subscriber, then also this will be your window into the revision tool. And part one will be a short 1.5-hour video today. Part two and three will be longer due to systemic pediatrics being obviously much more elaborate. So let us start with the NEET SS 2021. I'm using the word pattern MCQ because of technical reasons. So the question asked in NEET SS 2021 was MGRS charts are useful in which age group? They are useful in which age group? So what are the options we have available? 0 to 1 year, 0 to 5 years, 0 to 12 years, and 5 to 18 years. Now, MGRS, also called as multi-center growth reference study, was a study conducted by WHO, and it collected data from multiple countries, including India. And the data was collected in the age group of 0 to 5 years. So MGRS charts, MGRS growth standards are useful in which age group? They are useful in the age group of 0 to 5 years. They are useful in the age group of 0 to 5 years, and that is your answer. I know it's an easy question. It's also a frequently asked Viva question, but again, NEET SS will always have a mix of easy things and tough things. So let us do a quick review. Let us start with the first thing, that is growth patterns in child. So what is the normal weight gain pattern? And gradually I will be coming to this question that I just discussed with you. What is the normal weight gain pattern? 90% of the things I'm discussing, you might be knowing them. 10 per, if you know it already, it will be a revision for you. 10% of the things might be new for you, and these 10% things plus that revision is going to matter as you will realize when you sit in the exam. So weight gain pattern, what is the normal weight gain pattern we are going to discuss. So normally what happens is, normally suppose the birth weight of a child is X, right? In the first 7 to 10 days, in the first 7 to 10 days, every child loses, every child loses up to 7 to 10% of the body of the birth weight if it is a term newborn. And if it is a preterm newborn, the child loses between 10 to 15% of the birth weight if it is a preterm newborn, right? So if the birth weight was, say, 3 kgs at birth in a term child, that weight will reduce by about 250 to 300 grams in the first week. By 10th day, by 10th day, the birth weight is regained. By 10th day, the birth weight is regained. What it means is that if the birth weight was 3 kg at birth, by 10th day, 9th or 10th day, it will become 3 kg. And beyond 10th day in a term child, beyond 10th day in a term child, child will be gaining 20 to 40 grams of weight gain per day till 3 months of age. Till 3 months of age, right? And between 3 to 12 months, between 3 to 12 months, between 3 to 12 months, every child will be gaining about 400 grams per month. This is the normal weight gain pattern that you need to remember. You also need to understand that regaining of birth weight by 10th day is applicable in a term baby. In a preterm child, it can be regained a bit late because you can write in bracket like this, that in a preterm child, the regaining of birth weight can be delayed by 14th day of life. So the process is a bit slower. The weight loss is a bit higher in a preterm child, but generally, if term preterm is not mentioned, the values you are supposed to remember are related to a term newborn, right? So because I don't have a script in front of me, but I have a collection of topics that I'm going to discuss. Bear with me, and that is why I'm not having a look at the live chat as well. But in between, when I have to take a break, then I will be having a look at the live chat and then I will be answering it. So these are the weight gain patterns that you need to remember. Also, I hope you know that weight gain patterns tell you that there is also a method called as ready reckoner. That is something you already know. I need not write it. I have discussed in details in my videos, the detailed videos, that suppose the birth weight is X. So doubling of birth weight happens by 5 months, tripling of birth weight happens at 1 year, quadrupling happens at 2 years, and so on. So these are the values, these are the formulas which are called as ready reckoners, and you have already known them. But about this, why have I written them here? Because what is the average birth weight beyond 10th day till 3 months of age is your NEET Super Speciality 2018 MCQ. I know many of you do not have access to recall. The problem with NEET SS exams is recall. We don't get high quality recalls because the number of people giving the exam is limited. And unlike NEET PG aspirants or NEET UG aspirants, after giving the exam, people are a bit more chilled and they are not very into it, that recalling the options and sharing with. So what we end up with is a collection of topics. We end up with a collection of topics. Exact questions are not available, but we know students have said that there was a question related to this asked in NEET SS 2018 exam. It's a bit old question, but still a one-liner, and that is why we are discussing it here. So first thing is the weight gain patterns in the child. Second, we come to the height gain pattern in the child. Now, what is the height gain pattern? Some of the values we have discussed, some of the values additionally we will write. So at birth, every normal term baby is about 50 centimeter in length. What is the difference between length and height? Both are same. Conventionally, less than 2 years of age, you use the word length. Above 2 years of age, you use the word height. So at birth, the average length of a child is roughly 50 centimeter. At 3 months, it becomes about 60 centimeters. At 6 months, it becomes 65 centimeter. At 9 months, it becomes 70 centimeter. And at 1 year, it becomes 75 centimeter. Now, the question asked in the exam NEET SS MCQ 2019 question. 2019 MCQ was, what is the height velocity? What is the height velocity in first year of life? Now, height velocity means how much a child gains in the first year of life. So 75 minus 50, that is 25 centimeter in 1 year is the answer. So this is the MCQ you are supposed to remember. Also remember that height velocity is maximum in the first year of life. It is maximum in the first year of life. As age increases, the rate of height gain tends to fall. How does it tend to fall? So it is at 2 years, it becomes about 87.5 to 90 centimeter. And at 4 years, it becomes 100 centimeter. So normally what happens is, you can remember like this, that height velocity in a patient, height velocity in a child, in a normal child, in the first year is about 25 centimeter per year. In the second year, it becomes 12.5 centimeter per year. How you are remembering it? How you are remembering it? See, from 75 to 87.5, it is 12.5 centimeter gain which is happening. So 12.5 centimeter per year. Third to 6 years, it becomes about 6 centimeter per year. 6 centimeter per year. And between 6 to 12 years, it becomes 5 centimeter per year. Between 12 to 15 years, you will have the puberty coming in. So pubertal growth spurt will come. Pubertal growth spurt will be different for boys and different for girls. Those points we will be discussing when I'm discussing endocrinology on LRR part 3. So I will be discussing those pubertal changes, phenomena, one-liners at that particular time. So this is a height velocity chart. It's very, very important. And in fact, if you track, there is a pattern in INISS. This is a discussion meant for NEET SS, but you all know that NEET SS, INISS preparation is not exclusive of each other, although the pattern and weightage varies. So in INISS, this particular table is very, very important. So if it is important for INISS, it is important for NEET SS also. So remember this table, write it down somewhere and keep revising it as you prepare. So this is the second thing regarding revision you need to know. For those who are asking, sir, would this video go up on the app? This would be available to you till NEET SS exam on YouTube as well. And of course, better yahi hai ki you try to listen to it live, because you can always relate better and you can always understand the key points better and ask me the questions also. Then we come to the third thing, OFC gain patterns. What is the OFC gain pattern in the patient? OFC means occipitofrontal circumference, also called as head circumference gain pattern. Now, at birth, the average OFC in a child is about 34 centimeter in Indian children. This is according to the Indian textbooks. Indian textbooks like OP Ghai 10th edition as well as IAP textbook, both of them give a similar value of average 34 centimeter. Although your clinical manuals will be giving a range, but examiners will sometimes put a single value. So it is 34 centimeter average. What is the rate of growth of OFC? So OFC velocity you need to remember, but OFC velocity you cannot remember per year. It is always monthly or 3 monthly or 6 monthly that we need to remember. So rate of growth is first 3 months, a child gains OFC at the rate of 2 centimeter per month. And I'm putting a small Q. This is not a NEET SS question. This is a INI-CET question recently asked in 2024. So you will ask me, sir, INI-CET क्यों पढ़ा रहे हो? I'm preparing for super specialty. Same examiners, same mindset. And if you have tracked INI-SS exam, some degree of overlap does occur in the easy questions of INI-CET and INI-SS sometimes. It was asked last year. It does no harm in remembering this point additionally. So what is the OFC gain in the first 3 months? It is 2 centimeter per month in a normal child. 3 to 6 months, it becomes less. It becomes 1 centimeter per month. Between 6 to 12 months, it becomes 0.5 centimeter per month, and then it tends to slow down. And generally by 12 years, you can remember that by 12 years, I'm writing it here, by 12 years of age, average OFC of 52 centimeters is reached, which is almost the same as adult head circumference, right? So by the age of 12 year, OFC of 52 centimeter is reached. In between values, They are not mentioned also, except one clinical manual, and they are not needed also. Now, moving towards the growth standard. Now, the question which I was talking, whenever you have to do growth assessment or you have to use charts, two types of growth standards or charts are available. If you have to do growth standard assessment between 0 to 5 year, you will be using which charts? You will be using MGRS charts. MGRS charts or MGRS growth standards will be used. MGRS stands for, as I told you, it stands for multi-centric growth reference study. Multi-centric growth reference study. This was a study done by WHO, and in case a question gets asked from community pediatric part, they may ask you MGRS study of WHO was done in which countries? It was done in multiple countries, including India. So it was done in India, it was done in Brazil, it was done in Ghana, it was done in Norway, it was done in Oman, and it was done in United States of America. So 6 countries predominantly contributed, although other countries were also included, but eventually it was those studies were not completed and they were omitted from the final result. So final result included these 6 countries. You are supposed to remember this from community pediatric point of view. What are the country data which is used? So what was the answer? Ki MGRS chart, which age are we using them? 0 to 5 year was the answer. Now, but the data for this MGRS is only available till 5 years. So above 5 year of age, you have to depend upon country specific data. United States of America depends upon the CDC charts. We don't use the CDC charts anymore. We follow between 5 to 18 year. If the MCQ examiner asks you, you will be using IAP charts. So remember the funda. 0 to 5 year, we are using MGRS growth standard, also called as MGRS WHO charts. And 5 to 18 year, you are using Indian Academy of Pediatric charts. Now, SMR staging should be used after what age? It should be used after 7 years of age. What is SMR staging? Also called as Tanner staging. The sexual maturity rating. Whenever you do examination of a kid, normally you take vitals, you take anthropometry, and you then start with the general examination. But as a part of anthropometric phenomena, you should be talking about SMR staging after 7 years of age. Now, many of you might be asking, sir, but puberty comes later. To have that margin of error where early onset of precocious puberty can occur, you are taken, generally, conventionally, we start taking from 7 year of age onwards. Then OFC monitoring needs to be done till what age? OFC monitoring, according to all the guidelines, need to be done in a normal child till 3 years of age. After 3 years, OFC monitoring is not recommended. And what about frequency of body mass index monitoring? It should be done between the age group of 6 to 18 years, and it should be done yearly in the patient. So this is frequency of monitoring, one-liners. Out of them, the first one is already a NEET super specialty MCQ. Then nutritional indices. Let us start with the 3 important nutritional indices. A child comes to you, you want to assess degree of malnutrition in the child, how you are going to assess in the patient. The first nutritional index that you will be using is weight for age chart. How do you calculate weight for age? What you can do in the patient is, suppose you are sitting in OPD, patient comes to you, mother says, my child is not growing well. Using formulas or tables, you take the ideal weight of the child. You all know Week's formula, right? So you can use that as well, although it calculates weight on the higher side in Indian children, but you will first take the ideal weight and write it down. Then you will take the current weight of the child in this child and write it down and take out the percentage. So weight for age says, if weight for age in a child, is less than 80% of expected, we say the child is having undernutrition or malnutrition. And the term used for that is underweight child. The term used for that is underweight child. But this definition is interpretation is the older interpretation. It is not very possible to use this in every child. So what we do in every child these days is we take the help of charts. You can have a look at this chart. Can you see this is a weight for age chart? How would you know this is a weight for age chart? X-axis is showing age, Y-axis is showing weight. You have the mean line, you have +2 +3 standard deviation score, also called as Z score, -2 -3 standard deviation score, also called as Z score. And pink chart is for girls, blue chart is used for boys. So it is a weight for age chart for girls. For a boy, we will be using a blue color chart. And also see what age group it is being used. WHO chart is MGRS chart 0 to 5 year. So you see 0 to 5 year WHO chart, and 5 to 18 year you will have IAP charts, right? So this is just an example I'm showing. So this chart you will take. Suppose a 3-year-old child comes to you. You don't need to do mathematical calculation. You will take the current weight, current age, and plot on this chart. If when you plot on this chart, you find when you plot on a chart, if weight for age is below -2 standard deviation score, also called as -2 Z score, then also the child is said to be underweight. Underweight child is having undernutrition or malnutrition. There is a stratification also which you can do. If it is between -2 to -3 standard deviation, we call it as moderately underweight. If it is below -3 standard deviation score, we call it as severely underweight. So this is weight for age index. But weight for age index has two major limitations. So what are the limitations associated with weight for age? First problem with weight for age is it is not very accurate. It is not accurate in a patient who's having edema. Do you know any edematous malnutrition? Yes, you know, you're all pediatricians. But still, I have to ask you, it is kwashiorkor. Kwashiorkor has edema. And due to edema, the weight may become falsely high. So when you plot on the chart, it may not give you accurate assessment of malnutrition degree in the patient. And that is why weight for age is not accurate in any child who has edema due to some reason. For example, kwashiorkor. Second, weight for age index. It gets affected in both acute malnutrition as well as chronic malnutrition, and so cannot distinguish between them. So it cannot distinguish between them. Let me give an example of this. Suppose a child with diarrhea since 5 days come to you. His weight for age will become low. So acute malnutrition will cause underweight child. Second child with chronic renal failure, chronic kidney disease comes to you. You do weight for age, it will be low. So chronic illness can also call it. Third child is having both acute and chronic. When you do weight for age will be low, underweight child. You will not be able to say what exactly was the reason. Was it acute alone? Was it chronic alone? Or both acute and chronic are causing? So it is not a very reliable index. Remember, weight for age is not a sensitive or reliable index to ascertain whether it is acute or chronic malnutrition. It is not a very sensitive or reliable index. Think of weight for age as jack of all trade, master of none. Most of these points I'm writing, you know them already. Statement-based questions are asked. Weight for age, weight for height, height for age. Statement-based questions have been asked. Alternate year in NEET super specialty. The problem is long statements have been asked and the exact statements have not been recalled. And that is why I'm discussing them, giving examples so that whatever option gets asked, you are at least mentally ready from a revision perspective. So weight for age, you can remember, it is used to identify malnutrition, but it is not reliable. It is jack of all trades, master of none. Gets affected in both acute and chronic, but not reliable for either of them, not sensitive for either of them. Weight for age is that person in your medical college or in your medical school who says to everyone, I am your best friend, I am your best friend, I am your best friend. But this person who says to everyone that I am your best friend is not the best friend for anyone, right? So first is weight for age. Second index is weight for height. Weight for height cannot be used. You cannot use mathematical calculation. Chart has to be used. And the chart used here is, again, I've taken the example of WHO MGRS chart, weight for height or length, weight for length chart. So on the x-axis, you have height or length. Y-axis, you have weight. Child comes to you. Parents say malnutrition is present. When you are suspecting acute illness, then you will be using which chart? Weight for height chart. Weight for height chart is very sensitive. It is very sensitive, very reliable for acute protein energy malnutrition or acute undernutrition. It is not very sensitive. It is not useful. It is not affected in case the patient is having chronic malnutrition. So what does weight for height says? If you plot on the chart and you find weight for height is between -2 to -3 standard deviation score, you say the patient is having wasting. And presence of wasting indicates moderate, acute undernutrition. And if weight for height is below -3 standard deviation score, when you plot, it is called as severe wasting. And severe wasting indicates what? It indicates severe, acute undernutrition. It indicates severe acute undernutrition in the patient. So this is the second index, that is weight for height. And the third index is height for age. Height for age is an index which is useful. It is used in chronic malnutrition. When you are suspecting chronic protein energy malnutrition, you will be using height for age. Height slowly बढ़ता है, height increases slowly, so you will be using it in chronic malnutrition. So it is used in chronic malnutrition. It is not affected in acute malnutrition. It is not affected in acute malnutrition. So what is the index? What is the interpretation? I will write below this chart because I think some of you may be having difficulty in seeing because my face is coming in the front. So if height for age is between -2 to -3 when you plot on this chart, you say the patient is having stunting. And stunting indicates moderate chronic undernutrition. It indicates moderate chronic undernutrition. And if height for age is below -3 standard deviation score, we use the word severe stunting. And severe stunting will indicate severe chronic undernutrition. So height for age is an index for chronic malnutrition in the child. So severe stunting will be severe chronic undernutrition. Severe chronic undernutrition. This is something you already know, but someone has to say it so that you revise it because you will have a lot of systemic things getting revised. Let us be honest, nutrition part gives you less questions in NEET SS if you go by the current trends. But questions are asked, and you know that every question matters. So generally about 2 to 4 questions are asked. But again, 2 to 4 questions, every question matters in the paper, right? So this is height for age. Then we move further and talk about the thing that I was talking about that we have to discuss in detail, that is overnutrition and obesity. What are the changes which have happened? So first of all, this is based upon 3 textbooks, 3 references I'm using: IAP 2023 guidelines, Nelson 22nd edition, and OP Ghai 10th edition. So I am combining all the 3 together, and these are the ones which are generally used by your NEET SS or INISS examiners in their references. So how do you define obesity and overweight child? What was the older definition? The older definition was CDC or WHO international chart, and the chart used was for BMI for age. It used to say that any child with, when you take a BMI for age chart and you plot on it, if the child is lying between 85th to 95th percentile, we would say the child is overweight. And if BMI for age is more than 95th percentile, we used to call it as obesity. This was the original definition. But this definition has now been changed. Why it has been changed? The Asian population, including Indians, they tend to have adiposity and increased cardiometabolic risk at lower BMI. And hence, the International Obesity Task Force and WHO, I'm just reducing my face chair length a bit so you can see more text on the screen. So they have recommended that lower cutoffs should be used. Lower cutoffs should be used to define overweight and obesity in the Asian children. So what are the definitions you are supposed to remember now? The new definition says in Indian children less than 5 years of age, in Indian children, age-wise cutoff, less than 5 years of age, you should not use BMI. You should use WHO weight for height charts. So very, very important. Weight for height charts should be used in children less than 5 years of age. Some of you might have been doing it already. but you have been doing it already because the proposal was given in 2022. Some medical colleges implemented in 21 and 22 also, but proper systematically it was adopted in 2023 onwards, right? So WHO weight for height chart should be used to diagnose overweight and obesity. And for that, we say that if the child is having weight for height between +2 to +3 standard deviation, remember -2 to -3 was moderate wasting. Here we call it as overweight child. And if it is above plus equal to or above +3 standard deviation, we call it as obesity in the child. So overweight, obesity, less than 5 years of age, what is the index you are using? What is the definition you are using? The chart you are using? It is WHO weight for height chart. Secondly, if the age of the child is above 5 years till 18 years of age, you will be using IAP-based BMI charts. So you will be using IAP, but not weight for age charts. You will be using BMI charts in the patient. And these are the two types of charts separately given for girls and boys. So plotting on this, you will be defining the you'll take out BMI, you will take age and plot on this chart. And this chart is basically telling you children with overweight, children with obesity, and even the class of obesity in the patient. And similarly, it is for girls, similarly, it is for boys. Also, you need to remember that these cutoffs are different. So you can remember that overweight definition, the overweight line in these charts corresponds to BMI of equal to or more than 23 kilogram per meter square body surface area in adults. And obesity line corresponds to BMI value of absolute BMI value of equal to or more than 27 kilogram per meter square in case of adults. So this is what the definition is. Now, the entire article you can read in details. Obviously, the details will be mentioned there, but this particular thing you need to remember. It's very, very important. So obesity line will correspond to BMI equal to more than 23 for overweight and equal to more than 27 BMI in case of adults. And if there is anything you want to, there is something coming to your mind or you want to look at it again, I repeat, this video will go up on the YouTube, so you can have a look at it later as well. Moving further, what are the causes of childhood obesity? Now, the causes of childhood obesity can be divided into two parts. According to the latest guidelines, you have exogenous or primary obesity, which is more than 90%, and endogenous or secondary obesity, where there is a secondary cause available. There is a disease in the patient that is seen in less than 10% patients. Now, look at the primary or exogenous causes, parental factors. So, if one parent is obese, 40% risk. If both parents are heavy, 80% risk the child will have obesity, even if the child does not have a disease. Earlier, it used to be called as familial and constitutional factor. Now that word familial and constitutional has been removed. It's a very important thing. It has been removed. They directly use the word parental factors. Then prenatal factors. If maternal BMI was high, mother had gestational diabetes, and mother had excess weight gain in pregnancy, chances of childhood obesity, not just in the newborn period, but also in the first decade of life, it is high. Then lifestyle. Children who are inactive, sleep issues, excess screen time, playing Call of Duty and PUBG all day, these kids will have higher chance of obesity. Dietary factors like formula fed, bottle fed kids. If you have seen all the kids who are brought to your OPD, and if you ask them that the child is on Cerelac and all these formula milk, you will find that kids are more plump. A plump child is not always healthy. And many of these kids are, sitting on the border of obesity. It is not the brand per se, or it is not the problem per se. It is the lack of normal diet and a more energy dense diet that you find in formula feeds and ready to use feeds that is responsible for obesity. And processed food, trans fat, carbonated beverages, and nocturnal snacking. Children sleep late and they have a habit of munching something. And these days, popcorns and all those things are so easily available. And kids themselves learn at night to make popcorn. After 5, 6 years, they will go to the kitchen, turn on the put some ready to make popcorn, have them while watching a movie. Parents are sleeping because both parents are working. and child is is having deficit of parental attention, but he has all the gadgets and all the facilities available, contributing to obesity. So lifestyle is important. Then environmental and policy factors like easy supermarket access. Think of Zomato, think of Blinkit, 10-minute delivery. Kids are doing it. One of my relatives' kids is 7 years. He is using Blinkit app. So it's not the app, it is the lack of parental control, which is allowing all these, risk factors to accumulate. And paucity of gardens and commercials for high fat, sugar, and salt containing foods. HFSS are high fat, salt, and sugar foods. These are the exogenous factors. Then you have endogenous factors or secondary obesity. This will have the typical disease causes. Endocrine factors, there is a list given, you can remember it. Monogenic disorders, three types of mutations and deficiencies, I have discussed in detail video, you can remember it. Syndromes like Prader-Willi and Bardet-Biedl syndrome. Neurological causes including Rohad syndrome is one of the favorite of examiner. I will discuss when we discuss oncology one-liners. Rohad syndrome is very, very important. For unknown reason, it is one of the favorites of NEET SS and INISS examiner. Every alternate year they put it. So Rohad is associated with neuroblastoma, and it is one of the contributors of obesity among the pathological causes. Then drug-induced like steroids and anti-epileptics, psychological causes, child abuse, autistic spectrum disorder, and ADHD. All of them can cause secondary obesity. So remember the causes and the points which are included in this. Moving further, what are the red flag signs for pathological obesity where it is never likely to be primary obesity, and there is always a secondary reason, and these children need detailed evaluation. If there is early onset obesity within first few years, if the obesity is associated with short stature. Thirdly, if there is hyperphagia, which is non-discriminatory, har tarah ka khana, he is always eating. It could be a feature of Prader-Willi and Bardet-Biedl. Both of them are having polyphagia. Dysmorphism, facial dysmorphism, obesity can be syndromic. Associated features like developmental delay, vision problems, and behavioral problems again indicates a syndromic obesity. History of steroid intake will indicate a chronic or inflammatory condition in the child, and hypogonadism again indicates some syndromic cause of obesity. So these are the red flags for pathological obesity in the child. Then what is the IDF criteria for metabolic syndrome in children? Very, very important. Already MCQ, I'm marking it here. MCQ asked in INISS, I think it was April-May exam in 2022. So first half of INISS 22, general pediatric part, they had asked IDF criteria. So what is the IDF criteria? The adult criteria varies a bit. So IDF criteria is only applicable in the age group of 10 to 16 years. Less than 10 year, it is not validated. Above 16 year, you are using adult value. So what does the criteria says? Criteria says the criteria include, first of all, obesity. When do you say obesity? The waist circumference of the child, also written as WC, should be above 90th percentile for age, gender, etc. and age, gender, and racial factors. So above 90th centile, waist circumference should be present, above 90th centile. Second, there should be raised triglycerides, so hypertriglyceridemia. So second factor is hypertriglyceridemia. What is the cutoff? If the serum total triglycerides are equal to or more than 150 milligram per deciliter. Third factor, if the child is having low HDL. HDL-C is low HDL cholesterol. It is the good cholesterol if the value is less than 40 milligram per deciliter. By the way, I got my own lipid profile done, and my own HDL came to be 36. So telling to others to have a healthy lifestyle is good, but only when you get yourself tested, then you realize. So all the advice that I will be discussing with you, that is applicable to myself as well. We all, as you go up, as you go from residency to senior residency to consultancy, your physical activity diminishes. And so it is very important that you have a healthy lifestyle. So it's not only for the kids, you should also have it. So low HDL-C in a child, less than 40 milligram per deciliter. Then BP. If the patient is having hypertension, how do you define hypertension cutoff for metabolic syndrome? If the systolic BP in the patient is equal to or more than 130, or diastolic BP in the patient is equal to or more than 85 millimeter of mercury. If you have read the IAP guideline article, there is a misprinting there. There they mentioned diastolic BP less than 85, which is wrong. So don't remember wrong values. It is equal to or more than 85, not less than 85, right? So this is a misprinting in the article. You can check it. Fifth is hyperglycemia. So glucose value, hyperglycemia. If the blood glucose value, or the fasting blood glucose value is equal to or more than 100 milligram per deciliter in a child. So when do you say metabolic syndrome is present? If obesity, that is waist circumference above 90th centile, is present with two or more of features mentioned from 2 to 5. Then we say it is criteria fulfilled for metabolic syndrome in the child. There is a question already asked on this in INI super specialty exam. So this is very, very important and you need to remember it. You need to revise it before the exam. Questions do get repeated sometimes. Moving further, we have one-liners, collection of one-liners. What is the most important clinical parameter to determine metabolic syndrome and visceral adiposity? It is waist circumference. In Indian children, waist circumference more than 70th percentile. It is not a criteria for metabolic syndrome, but it can be used to identify children at risk of developing metabolic syndrome. So cutoff is 90th percentile, but at-risk children in India, waist circumference is more equal to or more than 70th percentile. So दो अलग-अलग चीजें हैं. These are two separate things. Don't mix them in the exam. These are at risk, and 90 and above is one of the criteria fulfilled for metabolic syndrome. Then most sensitive index for visceral adiposity and total body fat is not waist circumference. Investigation, if they ask, it is DEXA scan. So clinical parameter is waist circumference. Investigation is DEXA scan. Wordplay examiner can do in the exam. Don't make that mistake. Then what is the most common chronic liver disease in obese children? You can remember non-alcoholic fatty liver disease, also called as MASLD. MASLD stands for metabolic dysfunction associated steatotic liver disease. This is the new name for NAFLD used in children also, and the same terminology is used in adults also. Then if you have non-alcoholic fatty liver disease, you have to use serum ALT as the screening marker in children with these patients. If there is an elevation more than 2 to 3 times of the normal value, age appropriate normal value, that is a clue. It is not a very sensitive, it is not a very specific test, but it has reasonable sensitivity and so useful as a screening test in these patients. Now, what should be the physical activity per day in a child? What are the guidelines? IAP, American Academy of Pediatrics, both of them say the similar thing. Any child, to prevent obesity, the physical activity per day in a normal child should be at least 1 hour per day. And that physical activity should be a mix of running, jumping, walking, and moving around. At least 1 hour per day physical activity. It need not be going to a gym or cycling. It can be a mix of the activity. Then what should be the screen time per day? 3 ages are defined by American Academy of Pediatrics as well as AAP. Age less than 1 year, screen time should be nil. No screen time. Screen time includes mobile screen, laptop screen, TV screen. So age less than 1 year, nil. But what do you see these patients? Child is crying, 7-month, 8-month child. Parents will turn on those, apps are there, or the Pokemon is there. They will turn it on and make the child sit in front of that. Recommendation is nil, less than 1 year. Age 1 to 5 year, up to maximum 1 hour per day. And 5 to 10 year, it should be up to 2 hours per day, not more than that. Beyond 10 year, guidelines are not there. It needs to be rationalized according to the needs. And the lesser it is, the better it is. Now, avoid caloric restriction below what age? It should be restricted below 6 years of age, right? Below 6 years of age. Then, what are the drugs approved by FDA for pediatric obesity? This particular point again, it has not been asked. I'll be honest, it has not been asked. I'm an examiner. I will put questions on this. Drugs approved for pediatric obesity by FDA as of 2024. three drugs are approved for use, right? Not added in the regular videos. Updates, as I had promised you, I will be putting them as updates somewhere. You will get it. So if you're watching this session, this is what you need to remember. First drug is Orlistat. Orlistat. Orlistat is given in TID doses orally. It is a gastrointestinal lipase inhibitor. It is approved for use in age group of equal to or more than 12 years. Second is liraglutide and semaglutide, subcutaneous injection. These are the ones which are very, very popular these days for obvious reason. Even celebrities are using semaglutide and liraglutide and their congeners. So in a childhood obesity, GLP-1 analogs is their chemical composition, and age equal to or more than 12 years, they are useful. And then phentermine oral, it is a non-epinephrine reuptake inhibitor. It is useful in the age group of equal to or more than 16 years for short-term use up to 12 weeks in the child. So three drugs are approved, but they should only be given by a qualified pediatric endocrinologist. MD pediatric person is not equipped to give that. The only exception is senior people, senior consultants who have been working for years and have experience in managing endocrine conditions, right? So if you're a fresh MD, child with obesity comes to you, my advice, don't try to be too adventurous, right? These drugs do have their own side effects also. Moving further, and there are MCQs, of course, asked. You know that every NEET SS exam will have 5 to 7 questions on drugs. So yaad kar lo. Every NEET SS exam has 5 to 7 questions on drugs. One drug will always be from cardiology. One drug to two drugs will be from neonatology. Sometimes caffeine citrate is asked. Sometimes dexamethasone details are asked. So you need to remember from that. Then 1 to 2 things are asked from endocrinology. They will be asking about growth hormone. They will be asking about pediatric obesity, not asked so far. I'm an examiner, I will be putting, and sometimes they will be asking about the typical anti androgen and anti-estrogenic compounds also used in precocious puberty, etc. So these are the drugs you have to go through and you have to remember, including like caffeine citrate and aminophylline. You have to remember their therapeutic levels also. So one of the session I will be summarizing as a rapid fire one-liner at one place, right? So these LRRs are going to just give you that ready-made information. Here I'm focusing on obesity. I'm focusing on nutrition part and the topics which many of you have requested and which I feel are relevant for your exam. I'm trying to cover the PYQs of actual exam also simultaneously. Let's move further. Have a look at NEET SS 22 pattern MCQ, NEET SS MCQ. Look at the question and give me the answer. I can catch a bit of breath. So, a SAM child developed tachycardia, tachypnea, and hepatomegaly after the initial stabilization. So, what is a SAM child? Severely acute malnourished child, kwashiorkor and marasmic child. Stabilization phase, the child was admitted in hospital. He was given stabilization. Now, stabilization is over. Child is in rehabilitation phase, but he has developed tachycardia, tachypnea, hepatomegaly. What should you think of? Likely congestive cardiac failure is happening. Whenever stabilization phase, CCF-like manifestations happen, the patient is likely having refeeding syndrome. The patient is likely having, remember, any child in rehabilitation phase, if the child presents with congestive cardiac failure, seizures, and seizures, then the likely diagnosis in the patient is going to be refeeding syndrome. In refeeding syndrome, the hallmark is hypophosphatemia. So low serum phosphate will be the hallmark, right? And in case the patient presents with hepatosplenomegaly, parotid enlargement, ascites, increased hair, that is hypertrichosis, and eosinophilia. In these patients, you will think of which syndrome? You will think of nutritional recovery syndrome, also called as Gomez syndrome. Gomez syndrome. Here, there is no hallmark, but generally it is a group of features which is seen in the patient. So answer to this question, it has developed CCF-like features. So patient is likely to have hypophosphatemia. Almost all of you have answered correctly. Great. So let's go further. So इतना मुश्किल नहीं आता है question. You need to understand. But NEET SS is a horizontally spread. Something is asked from everywhere. Even your pediatric ophthalmology, even pediatric ENT, pediatric dermatology, they will also give you 1 to 2 questions. So it eventually comes down to कि आपने you are very good in cardiology, neurology, nutrition, milestone, and rheumatology, but you have not touched nephro and you have not touched the community pediatrics or ENT. You will face trouble in NEET SS. But you have done a bit of everything, you have a better chance in NEET SS. INISS, it's a totally different ball game. So yeah, in the remaining time, make sure that whatever you have done, you revise that, but also try to touch upon the causes of cataract in a child, one-liners related to hearing loss, external ear abnormalities, and the syndromes associated with them. For example, golden hair syndrome. Then you have Waardenburg syndrome, where there is a hair lock coming. So go through these as well. These are sometimes asked, but they are the rank deciding things in the exam, right? So this question will come. Such questions will come. You have to get them right. Some people will overthink and make silly mistakes, but eventually the rank deciding ones will be those tougher ones or those clinical questions which are from the non-core pediatric part in NEET SS, right? So we'll cover that. We'll cover that at least revision wise. जितना कर सकते हैं, whatever time we get, we will try to cover that. Ventilation graph, my dear friends, not commonly asked in NEET SS. It's very commonly asked in INISS. There was exception. Last year, there was one question asked in ventilation graphics. So if time permits, we'll try to cover that. But that is generally not asked in NEET SS. Biostats and ventilation graph generally not asked in NEET SS exam, right? Of course, there can always be a change. So let us talk about severe acute malnutrition. What is the criteria to define SAM? It is 2018 as well as 2019 MCQ of super specialty. What are the criteria? How do you define severe acute malnutrition in the patient? Any one of or more of the following, if it is present, we say the child is having SAM. What are the features? The first feature is severe wasting. Severe wasting. What is severe wasting? Weight for height below -3 Z score, also called as standard deviation score. Or if the child is having MUAC, mid upper arm circumference, less than 11.5 centimeter, that is also SAM. Or a child having symmetrical edema. Symmetrical edema. What kind of symmetrical edema? Generally pitting. So bilateral pitting edema of nutritional origin. So malnutrition with edema is also called as SAM. So these are the three features. Any one out of these three, if it is present, we say the child is having SAM, that is severe acute malnutrition. Now, if the child is having SAM, what are the two clinical subtypes of SAM? This is something you have already know, probably know better than me also. One of them is kwashiorkor, and second of them is marasmus. Kwashiorkor is the edematous malnutrition. These are the ones who have edema as well as mental changes. The hallmarks are edema and mental changes along with poor appetite. Whereas marasmic children, they will be having no edema. They will have no mental changes. They will be calm children. They will have alert children. They will have voracious appetite, increased appetite, always hungry. Then there are signs related to each of them, pot belly, flag sign, etc., etc. Those things you already know. जो पता है उसको यहाँ नहीं करेंगे because we have a very limited time available. So we'll only focus on the high yielding thing. ये बहुत डिटेल में हम कर चुके हैं और आपको आता भी है, right? So you just need to go through the tables, whatever source you are following. If you are already following SS pediatric at PrepLadder, I have discussed in full details to you. Kwashiorkor, it is multifactorial. These are the patients who have predominant protein deficiency. They have predominant protein deficiency. Plus, there is a trigger factor, acute illness or sudden weaning from the breast milk, and the child will fail to adapt. The child fails to adapt. That produces kwashiorkor. On the other hand, marasmus, it is predominant caloric, that is carbohydrate deficiency. They have no trigger factor, and the child generally adapts to starvation. So it is also called as adaptive malnutrition, right? Kwashiorkor because the child has swelling, so they are also called as fat sugar baby. It's an older name. Marasmic child is also sometimes called as flesh and bone malnutrition. Flesh and bone means it appears that only skin is there, which is covering the bones. There is no muscle and fat. Fat and muscle undergo atrophy. They undergo emaciation as a part of adaptation in marasmus. The features, the photos, if they show, you will obviously be able to identify. Now, grading of Kwashiorkor and marasmus. This is something you know, but you need to revise it because question on this has been asked in 2021 exam. Question asked in past year NEET SS. So first of all, we will be talking about grading of Kwashiorkor. Grading of Kwashiorkor. Kwashiorkor grading is based upon degree of edema, where the edema is present. So we have 4 grades. We have grade 1, where there is only pedal edema. If only pedal edema is present, that is grade 1. What is grade 2? If there is pedal edema along with facial edema, if it comes on the face also, we call it as facial edema. Grade 3, Kwashiorkor, is where there is above features, that is grade pedal edema with facial edema along with chest wall edema and back edema. Back is also written as paraspinal edema. Paraspinal edema. And grade 4, when the patient develops ascites. What is ascites? Free fluid in the peritoneal cavity. A mistake some students make clinically also, and I have seen it, people make it in rounds also. Of course, you don't get Kwashiorkor marasmic children that often these days. India is becoming more affluent, but in some states and some medical colleges, you will get these patients. So examiner generally says they will show a Kwashiorkor child and there will be a swollen tummy. I'll give you a case scenario which actually happened in one OSCE exam. I did not see it, but it was conveyed to me by one of my seniors, who's now a consultant in one of the regional AIMS. So he said there was a viva going on, and in the viva, photograph of a Kwashiorkor child was shown. So when they showed the photo of Kwashiorkor child had edema in the lower limb, child had some desquamation also happening, and the child had a swollen tummy, what you call as pot belly. So the examiner said the child also had edema on the face, but there was no edema present on the side. So the child was sitting and there was visible wasting which was visible, which was obviously indicating that there is no chest wall and back edema. Child had pot belly. So examiner showed the photograph and asked what is the grade of Kwashiorkor. Immediately the student looked at grade 4 and said, he looked at the pot belly and he said, sir, grade 4. Examiner laughed. He said, what is grade 4? He said, ascites. He said, what is ascites? He said, sir, peritoneal cavity में fluid. He said, photo देखकर तुम्हें कैसे पता लगा there is fluid in the peritoneal cavity? तुम सुपरमैन हो, तुम्हारे पास एक्सरे विजन है. These were the exact words used by one of the HODs of a leading medical college. Right? I'll not go into the specifics and details. It's a 2-year-old episode. True episode. मैं इतना creative नहीं हूँ कि ऐसा बना लूंगा. So it's a true episode. So you can well imagine what would have happened to that person who was giving the exam. Whether he passed or not, I don't know, right? So what examiner said was absolutely right. Looking at a pot belly, you cannot say it is ascites or not. Ascites is free fluid in the peritoneal cavity. You need to examine the patient, or there should be mention of ascites mentioned. You should know pot belly is multifactorial. Pot belly can occur even in the absence of ascites, even in grade 1 and grade 2. Why? Because Kwashiorkor has protein deficiency. Protein deficiency itself can cause muscle wasting, and laxity of anterior abdominal wall can cause protrusion of the abdominal content, leading to pot belly. Think of it like this. When you are having a big tummy and you want to reduce the tummy, when you go to gym, your gym trainer asks you to do plank exercise. When you do plank exercise and you do those crunches, the abdominal tone increases of the muscles, and that causes the belly to reduce, along with, of course, fat reduction as well. So it is the loss of tone also, which is a major contributor of pot belly. So if pot belly is present, you cannot comment if there is a swollen tummy. The student should have said, sir, it is grade 2. Why? Because It cannot be ascites without first involving chest wall and back edema. And chest wall and back edema was not present. The patient actually had grade 2 malnutrition. This is a learning point for you. And similar photograph can be put in super specialty exam also. You understand? Now that you have listened to it, you will be more careful in future and you will not make the same mistake. Right. So this is first thing, that is kwashiorkor based upon edema. These are the four grades you are supposed to see. Photograph if they give and ask you grade, has it been asked? No. Can it be asked? Definitely yes. मैं examiner हूँगा, मैं तो डालूंगा. मैं नहीं हूँ आपका examiner, but if I am examiner, I will put something like this. Watch out, see carefully. If it is grade 4, they will mention that patient is having, free fluid in the peritoneal cavity. Generally, the question will be on grade 1, 2, and 3. Examiner generally plays safe. Then we have marasmus. Now, marasmus, the grading is based upon fat loss, the site of fat loss, where the fat loss is happening. So we have grade 1 marasmus. Grade 1 marasmus is loss of fat from axilla and groin. So when fat loss occurs from axilla and groin, we call it as grade 1. What is grade 2? If the fat loss occurs from thighs and buttocks. What is grade 3? There are multiple ways of classifying, so there will be minor changes in the grading of marasmus. Grading of kwashiorkor is universal. Grading of marasmus, based upon the type, based upon the reference, you will have minor variation in grade 2 and grade 3 language. Grade 3 malnutrition will have chest wall, anterior chest wall, as well as abdominal wall showing loose skin fold due to fat loss. And grade 4 will be loss of buccal pad of fat. So these are the two types of gradings, kwashiorkor as well as marasmus grading. Let us move further. Talk about the two phenomena in SAM rehabilitation. I have already summarized them. The two types of phenomena are, first of all, we have the nutritional recovery syndrome. Nutritional recovery syndrome, also called as Gomez syndrome. What is the cause of nutritional recovery or Gomez syndrome? The likely cause, although it is multifactorial, the most important cause is excess proteins given in the rehabilitation phase in the diet. Clinically, what will be the clues in the patient? Clinical clues: the patient will have hepatosplenomegaly, patient will have ascites, patient will have gynecomastia. The child will develop gynecomastia irrespective of gender. Child will have parotid swelling, and there will be hypertrichosis, increased hair on the body. When you do blood examination, the blood examination will show eosinophilia, increase in the number of eosinophils. So eosinophilia will be seen. Treatment is conservative, and these patients, you need to reduce the protein intake. Don't stop it, but bring it down and slowly reintroduce. On the other hand, you have the refeeding syndrome. Refeeding syndrome is more commonly seen in marasmic children. Refeeding syndrome, the cause of refeeding syndrome in the patient, the cause is inappropriately excess calories. The cause is inappropriately excess calories in the diet. So high calories, too much of sugar content if you are giving, empty calories basically you are giving, it can cause a refeeding syndrome. Clues in the question will be CCF-like symptom. Examiner will not say CCF. He will say tachycardia, hepatomegaly, raised jugular venous pressure, cardiomegaly, tachypnea, S3 gallop, all these features he will say. And there will be CNS involvement in the form of seizures and altered sensorium. And blood picture, the hallmark of these patients will be low serum phosphate. Some patients can also have low magnesium levels as well. So low magnesium, hypomagnesemia is also a manifestation, and treatment in the patient will be, you need to give phosphate supplements. Reduce the caloric intake. Don't stop it. Reduce the caloric intake. Bring it in par with the protein intake, and CCF drugs will be needed. So anti-CCF drugs like enalapril and furosemide can be used. They will be needed for about 3 to 6 weeks. They are generally needed for 3 to 6 weeks, depending from child to child. So these are the two phenomena, clues I have written. You have to make the diagnosis. It's a revision session, so I'm not going into unnecessary details. Let's go further. Let's so answer to this question. It comes again. C, hypophosphatemia. Right. This is nutrition recovery syndrome. Scenarios and one-liners. Let us summarize. Where to manage a SAM child? Where would you manage? Again, there are potential questions which can be asked. Whenever a SAM child comes to you, kwashiorkor or marasmus, look for the following. What are the things you will look for? Is the patient having severe edema? Clinically, we call it as 3+ edema. Is the patient having any poor appetite? How do you say poor appetite? Examiner will not say poor appetite. Examiner will say the child has failed RUTF appetite test. The details of the test I have already discussed in the detailed video, so I will not write it here. So poor appetite, the examiner will say failed RUTF appetite test. Thirdly, there is any medical complication. There are medical complications I have discussed in regular videos. Shielded is the mnemonic for that. Or life-threatening signs like danger signs, like convulsions in the child. If any of them is present, any of them is present, so can you get PDF of the live session? It is not in my hands. PrepLadder SS team will be able to tell you better, but this video will be available to you, right? So any of them is present, the patient is said to have complicated SAM. And complicated SAM will require hospital management. They will require hospital management. And if none of them is present, you will say the patient is having uncomplicated SAM. And uncomplicated SAM can be managed at home. The term used for that is supervised home management. So you will be managing at home. So you can get a case scenario. They will mention and they will ask you where the child needs to be managed. Next, we have the total duration of hospital stay. Total duration of hospital stay is always 6 weeks. This 6 weeks is divided into two phases. You have stabilization phase. You have stabilization phase, which is for the first week of hospital stay, and then you have rehabilitation phase, which lasts from 2nd to 6th week. The aim of stabilization phase is to stabilize, to manage complication and save life of the child. Aim of rehabilitation phase is catch up growth. Which micronutrient should be avoided in the stabilization phase? Iron supplementation should be avoided. Iron increases free radical damage. Iron increases proliferation of pathogenic gut bacteria. And third thing, which is not mentioned in the books, but you know from experience, iron can cause GI upset and it interferes with nutritional rehabilitation of the patient anyway. Nutritional, introduction in the patient anyways. Right? So that is why iron, it can be added in rehabilitation phase, but it should be avoided in the stabilization phase. So Dindra Lakshman, yes, list of repeated and most important topics. Whatever topics I'm discussing in LRR sessions are most important. Apart from that, if you want some summary kind of thing, I will be posting it. And one of the coming session, I will post it for you. Right? Point taken, noted, I will do that. Next thing, how do you manage dehydration in a SAM child? There are two possibilities. You will remember like this. If the question says, if the examiner says, or if the patient coming to you, child has some or severe dehydration, but no shock. You need to understand one thing. Categorization of some and severe dehydration is difficult in a SAM child, right? So books simply say dehydration without, in the absence of shock. Management is different. But you can remember like this, some or severe dehydration, but no shock. And second possibility, severe dehydration with shock. Some dehydration will not have shock, right? So some severe dehydration with shock. You know what shock is. So if it is some or severe dehydration but no shock, you will be using oral fluids in the patient. Which oral fluid should be used? Resomal. Rehydrating solution for malnutrition. How do you make resomal? You have already discussed. I have discussed in my class. I will not write here. Paucity of time, paucity of space, but I will say so that you remember. Resomal is made. Take 1 packet of ORS. Normally, 1 packet of ORS is added to 1 liter of water. Now you will add 1 packet of ORS to 2 liters of water. Then you will add 50 grams of sucrose, chini, and 45 ml of KCl, potassium chloride. This is Resomal, right? This is Resomal. Nelson talks about standardized salt solution also. India में नहीं मिलता है standardized salt solution, right? So आपको ऐसे ही बनाना पड़ता है, and this is the Resomal fluid that you will be using. So how would you give Resomal? What is the amount that you will be giving? 5 to 10 ml per kg body weight per hour, and it will be given for 12 hours. So 5 to 10 ml per kg per hour for 12 hours. Case scenario will come. Child was started on Resomal, took for 2 hours, now not accepting orally. If not accepting orally, what to do? If the child is very stubborn, we are also stubborn. Putting IV catheter and giving IV fluid is tricky, and unless shock is present, you will not give IV fluid. So your answer will be, what is the next step in management? You can get a case scenario on this. If not accepting orally, but he has some to severe dehydration without shock, you will give Resomal via feeding tube. So NG tube or OG tube you can give to the patient. Only when that is also not possible, or there is MSS happening or vomiting happening, then or the patient has shock, then you will go for IV fluid, right? So severe dehydration with shock, you will be using IV fluid, which is the best IV fluid in these children. Special fluid called as Ringer lactate in 5% dextrose. So RL in 5% dextrose is the preferred fluid. I'm putting a star. How much you will give? You will give relatively slowly, although shock is present, but no rapid push. You give 15 ml per kg body weight IV over 1 hour. People ask, sir, kyun? These are children who may be having capillary leakage. They are having, even if they are having hypovolemia, they are also having capillary leakage, and they are having sodium and water retention, particularly kwashiorkor. It has been shown that if you give too fast a bolus, sometimes directly from shock, patient passes into pulmonary edema. So that is why we give 15 ml per kg IV over 1 hour. Monitor for shock improvement, watch for pulmonary edema, crepitations and overhydration thing. Then you will repeat 15 ml per kg over 1 hour. Same dose. If the patient improves, you will start the patient on Resomal. Shift to oral fluids, Resomal, and give for 10 hours. Why 10 hours? Because already 2 hours of fluid has been given. So MCQ can be asked in the exam. Total fluid correction needs to be done in SAM child in dehydration over how much time? 12 hours you should do it, right? 12 hours is the answer. And if the patient, if there is no improvement or the patient worsens, then you will treat as septic shock. So the typical septic shock management you will do, shift the child to IV, to ICU, pediatric ICU, PICU, and you will consider norepinephrine in the patient. Shock management summary, one-liners you will do day 3, LRR part 3, right? So let us go to the next thing. Management of anemia in a SAM child. Now child comes to you with anemia. 3 possibilities can be there. I will be doing it in a possibility format. HB of the patient is 7 gram per deciliter or above. There is no need for blood transfusion. You will give oral iron in therapeutic dose. What is the therapeutic dose? 3 to 6 milligram per kg body weight per day. Starting from what phase? From rehabilitation phase, right? Nothing urgent needs to be done. If the patient is having HB between 4 to 6 gram per deciliter with respiratory distress or congestive cardiac failure symptoms, or any HB less than 4, even if asymptomatic, these patients you will be giving blood transfusion. Which blood will be given? You will be giving not PRBC. Guidelines say whole blood transfusion should be given. Amount will be 10 ml per kg, given slowly, IV over 3 hours. 10 ml per kg IV over 3 hours. Don't over correct the HB in these patients. So 10 ml per kg IV over 3 hours, and you will consider, because these patients, I told you, capillary leakage is there. There is a risk of pulmonary edema. So you will give, consider plus minus furosemide, that is loop diuretic. Lasix injection can be given midway transfusion, but you need to monitor, plus monitor the patient, right? Monitor the patient. So this is what you need to remember regarding the management of anemia in a SAM child. And if the patient is having active bleeding or fluid overload with severe anemia, here PRBC will be preferred instead of whole blood. So these are the one-liners you can add to the notes. Some of the things I have already discussed, other things you can add to the notes. Let's go further. You will be giving albendazole to all children prior to discharge. What will be the dose of albendazole? Age less than 1 year, not to be given. Age 1 to 2 year till 23 months, the dose will be 200 milligram single dose. 200 milligram single dose. And if age of the patient is equal to or more than 2 years, you will be giving 400 milligram of albendazole single dose. I hope you know that albendazole is not given empty stomach, it is given full stomach. Fatty meal increases the absorption of albendazole. So tell the parents to give some fatty food to the child, preferably dinner, heavy meal, and then give albendazole. The absorption is increased. Then what is failure to respond to therapy? Two types of failure to respond to therapy in SAM have been defined, primary and secondary. Primary is said to be there if any one of the following is seen. If there is failure to regain appetite by day 4 of hospital stay, failure to start losing edema by day 4, if there is presence of edema by day 10, and if the child does not gain at least equal to or more than 5 grams per kg body weight per day by day 10. We say any one of them is present, it is failure to respond. Failure to respond to therapy in SAM is also a past MCQ point. Mark it and add it to the notes. What is secondary failure? During rehabilitation phase. Initially, the patient was responding, but during the rehabilitation phase, there is inability to gain equal to or more than 5 grams per kg body weight per day for successive days. Then we say secondary failure to respond. Identify the cause and treat the cause, right? So look at NEET SS MCQ. We are into the world of rickets. So a child with refractory rickets is not improving on vitamin D. Blood examination revealed a normal ABG, no acidosis, normal serum creatinine, so no RFTD range, cannot be CKD, MBD, normal serum calcium and high normal PTH. What is the next investigation to be done? Read carefully and give me the answer. What will be your answer? With a cool, calculated mind, think and give me the answer. This question is asking about approach to refractory rickets. High yielding topic, one of the favorite of examiners. In some way, every alternate year it gets asked in the exam. Last year, though, there was no SS exam. 24 is being held in 25. But 23 as well as 22, there were questions on refractory rickets. So would the hat trick be made this year? We don't know. You will tell me once the question gets asked. So last week topic is rickets, particularly refractory rickets for your exam. So what is your answer? One of you is answering FGF 23. Anybody wants to differ or you are sure of your answer? The answer is not FGF 23. I know you are thinking. Serum FGF 23 does not correlate well with the occurrence of, it is not a marker, it is a biochemical mediator in X-linked hypophosphatemic rickets, but it is not a marker and there is no such thing as serum FGF 23 in the patient. I was waiting for you, all of you, to mark B. The answer to this question is actually A. And 125 DHCC levels you need to do. How? Why? Let's make a chart and then it will be more clear to you, right? So this was the question when it was asked. Many good students also marked it wrong in the exam. Let us look at the approach to refractory rickets. You have given vitamin D, calcium, patient is not improving, refractory rickets suspected, how you are going to approach. Any patient with refractory rickets, First of all, look at serum phosphate levels in the patient. Look at serum phosphate. Two possibility. Serum phosphate is low or normal. And second possibility, serum phosphate is high. That is hyperphosphatemia. If it is high, the likely diagnosis in the patient is going to be CKD MBD. The clue in these patients will be get a RFT done, get a RFT done to confirm the diagnosis and give a pediatric nephro call. Okay. If it is in low or normal, the second thing will be getting a ABG done. Now get a ABG done. When you do ABG, there will be two possibility. Either patient is having, look at the pH of the blood. Look at the pH of the blood. Either the ABG will show acidosis or patient will show no acidosis. Either normal pH or alkalosis. If it is showing acidosis with low to normal serum phosphate, you should suspect the possibility of RTA, renal tubular acidosis. So work up for RTA. RTA is a topic we have discussed in detailed video. You will start with that evaluation and take obviously a pediatric nephro consultation. If there is no acidosis, now you will look at serum PTH and serum calcium. Serum PTH and serum calcium. You will have two possibility. First possibility, there is high PTH and normal to low calcium. High PTH, normal to low calcium. You will think of VDDR in the patient, vitamin D dependent rickets, two types, type 1 and type 2. And if the patient is having normal PTH and normal calcium, the patient is likely to have X-linked hypophosphatemic rickets. Now, in the question which I showed you, there is low normal PTH, and the patient is having normal calcium value. There is no acidosis, and there is normal serum creatinine. So the obvious next thing to do, it is not ideal. You should be doing a phosphate level as well, but serum phosphate was not in the option, and we have already done it before. So what you will be doing in the patient is doing the 125 DHCC level. In patient of type 1 XDDR, you will be having a very low level of 125 DHCC. Why? It has subtypes, but remember, type 1 VDDR is autosomal recessive condition. There is deficiency of 1-alpha hydroxylase. 1-alpha hydroxylase in the common variety of this. So 1-alpha hydroxylase deficiency means 25 hydroxyl vitamin D will be high, but 125 DHCC level will be low in the patient. In case of VDDR type 2, what is the cause of disease in the patient? Go back to the video, the detailed video. I have told you end organ resistance, lack of receptors on the tissues. So VDDR level will be very high, 125 DHCC. Whereas in X-linked hypophosphatemic rickets, in the presence of serum phosphate, there should be elevation. Low serum phosphate, there should be elevation in PT in 125 DHCC. But in these patients, there will be low to normal 125 DHCC. Age-related values will need to be done. And doing 125 DHCC will help you in narrowing the diagnosis and reaching the correct answer. Serum FGF23 is not used as a marker for X-linked hypophosphatemic rickets. It is involved in the pathophysiology, but it is not involved in the investigation. You can have a look at Nelson. You can have a look at the review article. You can have a look at the Indian textbooks. It is involved in pathogenesis, but it operates at a cellular level, and blood levels are not reflective of the underlying disease. And so the most likely answer among the option is 125 DHCC. Such a beautifully crafted question. And this shows that this flowchart and topic of refractory rickets is very, very important. Let's do a rapid fire quick review of rickets in the patient. I know screen के अंदर मेरा face cover कर रहा है थोड़ा सा, as I can see. I'm going to the side. You can see it here, right? Whatever I have seen, whatever I have discussed in X-linked hypophosphatemic rickets. Seen? Now let us continue. So one-liners on rickets. Now, a lot of one-liners we need to remember. They are asked in the exam. First of all, what about the blood picture in nutritional rickets? Remember that in nutritional rickets, the typical vitamin D deficiency associated rickets, the serum calcium level is normal or low. So normal serum calcium can also be seen in nutritional rickets because initially the serum calcium is low, but under the effect of parathyroidism, high PTH, the calcium tends to normalize. So serum calcium is normal or low. Phosphorus or phosphate level is always low. Alkaline phosphatase is always high. 25 hydroxyl vitamin D, which is the active form of vitamin D, the circulating form will be very low. PTH level will be high, and urinary calcium excretion, which is calculated by calcium to creatinine ratio, that will be low. This is again a very important recently asked question. Sorry. This is a recently asked question in INICT, not in INI SS, but it has been asked. So you can remember these values. So serum calcium में गलती करते हैं लोग, PTH में गलती करते हैं, and urinary calcium excretion. These are the three areas where students make mistakes sometimes. Next is, what is the treatment of nutritional rickets? Earlier we used to give a STOS regime. So STOS regime will be 6 lakh international unit single dose or 60,000 international unit for 10 days. Now we give a more gradual therapy. We give oral vitamin D3 supplementation daily for 12 weeks. Plus you will add calcium orally for the same duration, and calcium will be 50 to 75 mg per kg. Dose they will unlikely ask. Vitamin D3, if it is an infant, the dose will be 2000 international unit per day. If it is an older child, the dose will be 3000 at least to 6000 international unit per day. Generally, we use 3000 unit, but can go up to 6000 in slightly older child or with severe rickets as well. Now, what is the gene in XLHR? XLHR is X-linked hypophosphatemic rickets. It is FEX gene. And what is the FEX gene type of inheritance? These patients show X-linked dominant inheritance. So it can occur in girls as well. X-linked recessive do not occur in girls. So X-linked dominant inheritance. You need to remember X-linked dominant conditions. Rett syndrome, some varieties of Alport syndrome, incontinentia pigmenti, X-linked hypophosphatemic rickets, and there is a syndrome called as Gorlin syndrome. Right? They are all X-linked they are all X-linked dominant conditions. Then what is the biochemical basis of Beatles is saying, are these rapid revision videos which are supposed to be released in the app? No, 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 no. Those are different. Those are different. I've just done videos on galactosemia, paroxysmal disorder details. I have done some ventilation related one-liners. So those are separate videos. They will go for only subscribers. This is for all of you who want to summarize the things in the end. So this is separate. This is separate. That rapid revision thing is available only for subscribers on the app. What is the biochemical basis of XLHR? The normally FEX gene keeps the FGF23, fibroblastic growth factor 23 level under check. In patients, when there is FEX gene mutation, there will be elevation in FGF23. Not in the it will be in the blood, but the biochemical levels are not generally very suited for testing. Increased FGF23 level will cause two things. First of all, it will cause renal phosphate wasting. Renal phosphate wasting. Manmeet Singh Khalsa, FHHC can be there, but again, FHHC, if you're talking about the approach thing, where do you fit it? Again, it is very rare condition. So that can be a possibility, but generally in the flowchart based approaches that we take, FHHC is not mentioned there. We consider it as a variant, as a separate small topic on the side. So it will be very difficult to fit it in the normal chart. These are the charts which are given in standard books and standard guidelines. Smaller, rare topics, we need to discuss them separately, like for FHHC. Then increased FGF23 causes renal phosphate wasting, leading to hypophosphatemia. Secondly, increased FGF23 will interfere with 1-alpha hydroxylation. of vitamin D, leading to inappropriately normal to low levels of 125 DHCC. What will be the clinical clues? कैसे पता चलेगा? These patients are found to have severe lower limb deformity. So when they put a question, they will be putting questions where the child will be standing and there will be bow legs, knock knee or windswept deformity. So वो photo डालेंगे and severe lower limb deformity. Secondly, these patients will have recurrent tooth abscesses. So recurrent tooth abscesses will be another clue, along with refractory rickets, of course. So these are the two important clues that you need to watch out for. What is the treatment of XLHR? It is a combination of three things. You need to give oral phosphate supplementation because there is hypophosphatemia. Plus, you give calcitriol in the patient. Plus, you can consider, if it is available and if the cost is justified, you can consider giving monoclonal antibody called as burosumab. What is burosumab? It is anti-FGF23 monoclonal antibody. Anti-FGF23 monoclonal antibody. And lastly, clue for rickets, if they say refractory rickets with alopecia found in 70% individual, epidermal cyst also present, VDDR type 2 should be suspected. VDDR1 does not have a clinical morphology except for refractory rickets. VDDR2 and X-linked hypophosphatemic rickets have a very typical morphology or a clinical presentation. VDDR2 is brittle rickets, difficult, florid rickets, difficult to manage rickets, poor outcome. Very high doses of calcitriol can sometimes cause improvement, but the outcome generally is disappointing. So if they ask you what is the most severe form of refractory rickets, the answer will be VDDR type 2. And then we have some one-liners related to vitamin A. Now, vitamin A, what are the one-liners? First thing which was asked recently in NEET super specialty exam was RDA of vitamin A. अब इसको याद करना पड़ेगा, अब आ गया क्वेश्चन, तो you have to remember it. In case of infants, the RDA, the recommended dietary allowance, is 300 to 400 microgram per day. If it is a child, the dose will be 400 to 600 microgram per day. Even if you don't remember, now you have to remember it. एक hint देता हूं. If you are running short on time, don't remember the doses of water soluble vitamin, but remember the doses of fat soluble vitamin. A, D, E, K. These are the ones examiner has a higher tendency to ask in the exam. Okay, running short on time, risk लेना है, leave out water soluble. Ideally you should, but leave out and remember only the doses of fat soluble vitamin. अगर आ गया water soluble, don't blame me, but generally नहीं आता है. So this is a risk if you want to take. I'm just suggesting it to you. Taking things is also very dangerous thing. Then is adolescent period. If it is adolescent period, whether it is a boy or girl, the requirement will be same, 750 microgram per day. And if it is pregnant lady, the requirement will be about 800 microgram per day. So these four values you need to remember. अगर सब नहीं याद कर सकते तो at least this has to be remembered. They had asked about a child, which was the question which was asked in the exam. And also remember that whenever you are calculating RDA or the doses, that there is a conversion you need to do, that 30 milligram of retinol is equal to 1 lakh international unit of vitamin A. But generally, it is the microgram dose that we use in the patient. Now, what are the key points about vitamin A? One-liners you need to know. Vitamin A deficiency is associated with two predominant organs. Two organs are early affected. What are the two organs which are early affected? First of all, you have the eye involvement, which is called as xerophthalmia. Xerophthalmia. And second is your skin involvement, which is called as xerosis and related disorders. So xerosis and related disorder. For example, the patient will develop dry skin along with follicular hyperkeratosis. Remember this keyword. In vitamin A deficiency, there will be deposition of keratin plugs in the base of hair follicle. This is also called as keratosis pilaris. The skin manifestation of this will give an appearance what you call as phrinoderma, or toad skin appearance can sometimes be produced. Remember, Phrinoderma can occur due to vitamin A deficiency. It can also occur due to essential fatty acid deficiency. It can also occur in adolescents and adults due to atopic dermatitis, that is eczema, and psoriasis. Once I was teaching, a girl came to me in the break in a class and she said, Ki, sir, I am having, phrinoderma like skin. And she showed her arm. She had typical phrinoderma on the skin. So she asked, should I take vitamin A? I told her, vitamin A deficiency is rare in adults. She did not have any other symptom. I asked her any allergy history. She was a non atopic. So I simply told her to use a good quality moisturizer. It will go away. Right. So, child and adult, these distinctions we do need to maintain even in our day-to-day practice, right? So vitamin A deficiencies, even if you are having follicular hyperkeratosis is very common, very common. So if you're having that skin, use a good quality moisturizer, paraffin oil backs based. I hope you know the funda, atopic dermatitis. What do you read in Nelson? Barrier protection is the mainstay of therapy. If you keep the skin hydrated, barrier protection is the most important thing. For flares, you use steroids, but emollients, moisturizers are the most important thing. If your moisturizer has a very strong smell, perfumed, it is generally not a good emollient. Remember this funda in your clinical practice. So vitamin A deficiency. Beetle's remaining rapid revision videos, they will go up in the next 3 or 4 days. Mostly they have been done. Some editing has to be done. As I said in the beginning of this session, I was out of India. So I've just come today and straight from airport, I'm coming and taking your class. So I will be doing the editing over the next few days and they will go up. So paroxysmal disorders, galactosemia, I think it has already gone. And 6 to 7 more videos will also go up in less than next 4 or 5 days. So till then time, keep revising and please add these LRR to your revision. So, and when you do microscopy in these patients, when you do microscopic examination, what will you find? Goblet cell hypofunction as well as decreased number is found in many of these patients. So goblet cell hypofunction is a feature of vitamin A deficiency. Some more one-liners on vitamin A. What is the most common, what is the most common symptom of vitamin A deficiency? The most common symptom is what patient says, night blindness. Sometimes examiner does not use the word night blindness. They write delayed dark adaptation. Delayed dark adaptation. And if they say what is the most common sign of vitamin A deficiency, it is conjunctival xerosis. Conjunctival xerosis. Then there is a classification, the WHO classification of xerophthalmia that you already know. XN is night blindness. X1A is conjunctival xerosis. X1B is Bitot spot, the typical foamy feathery deposits found on the conjunctiva. X2 is corneal xerosis. X3A is corneal ulcer, less than 1/3 of the surface area, and X3B is corneal ulcer equal to or more than 1/3 of the surface area. XS is corneal scar, and XF is xerophthalmic fundus. So fundus changes are, this is the WHO classification. So sometimes they will give a photograph of Bitot spot and ask you the diagnosis. Classification, the classification will be X1B. In this table, divide these four into a separate category and call them as advanced xerophthalmia. What is the meaning of advanced xerophthalmia? This is a terminology not given by WHO, but mentioned in review articles and used in clinical setting. The first four, which are out of this box, XN, X1A, X1B, and X2, they can be managed by medical therapy alone. In the other four, which are included in the box, the corneal ulcers, the corneal scars, and xerophthalmic fundus, medical therapy alone is not sufficient to save vision. You need some intervention or surgery or cryotherapy or something to save vision of the child. So that is why it is called as advanced xerophthalmia. So medical therapy alone is effective till what stage? X2. After that, medical therapy alone will not be sufficient. You will have to use some intervention in the patient. So that is the funda behind advanced xerophthalmia. This is something I think I have not discussed in the regular videos, but some of you asked me as a doubt in my Telegram group and also personally, ki, sir, what is advanced xerophthalmia? It has been asked by many examiners in the Vivas also. So that is why I'm mentioning it here. It's not mentioned in WHO guideline or in Nelson, but it is used in Indian textbooks and review articles sometimes. That is advanced xerophthalmia. If someone asks you, then only you say, otherwise it is not a very scientific term. Then see, Arvind, it is not XS or XF. I've just written the names of the classification. Generally, scar is the end stage. This is the end stage. These classification are not in particular order. They are not in order. XS is the end stage. Fundus changes obviously can occur before a scar formation, right? Then what about vitamin A toxicity? Many times examiner asks about vitamin A toxicity. So I'm giving the heading hypervitaminosis A. Hypervitaminosis A. MCQ asked in NEET. Sorry. Got deleted. I will have to write again. Hypervitaminosis A. MCQ asked in NEET SS 2022. What was the question? I don't know. The only thing I got was, sir, there was a question on hypervitaminosis A. They had asked about clinical feature and they had asked to identify the incorrect statement. So let's discuss few points about hypervitaminosis A. A hypervitaminosis A is of two types. There is a acute type, acute toxicity, and there is a yes, Manmeet, I will discuss. Don't worry. So since you asked, I will discuss. I was hoping that you have read about it, but I will discuss. Don't worry. So acute as well as chronic toxicity. So first of all, we have the acute toxicity. Acute toxicity occurs whenever there is excess ingestion of vitamin A, over ingestion of vitamin A doses beyond recommended doses. What are the recommended doses? That I will mention acutely. If the doses are taken acutely, then the doses, suppose it's a 2 kg child, 3 kg, 3-year-old child, otherwise normal, has vitamin A deficiency. So dose will be 2 lakh international unit today, tomorrow, and 2 weeks later, right? Now, instead of 2, 2, 2, now the child takes 8, 8, 8, or he takes 2, 2, 2, 2, 2, 2, 2, like that. Sometimes this also happens. That will cause acute toxicity. Acute toxicity will generally manifest in the form of pseudotumor cerebri. So these patients will present with pseudotumor cerebri. Some of them can present with loss of appetite, and they can present with isolated vomiting. Vomiting can be a part of pseudotumor cerebri. It can be present without this as well. So there will be features of raised intracranial pressure in the patient. Treatment will be sometimes you have to admit the patient. You have to consider giving carbonic anhydrase inhibitors. For example, acetazolamide. You have to consider therapeutic lumbar puncture, and these patients may require hospitalization and supportive therapy. Second is chronic. Chronic hypervitaminosis A occurs if the patient consumes more than 50,000 international unit per day vitamin A for more than 4 to 6 months. If they don't ask a range, more than 6 months is what you will be marking. So any ingestion, oral ingestion of 50,000, more than 50,000 international unit per day for more than 4 to 6 months will cause chronic hypervitaminosis A. Now, in these patients, the features will include poor appetite. So loss of appetite will be there. They will have bony pains due to bone turnover. Chronic hypervitaminosis A causes activation of osteoclastic activity. So there will be bony pain. There will be sometimes hypercalcemia and hypercalciuria. There will be hepatosplenomegaly, and there will be alopecia. And treatment in these patients is more of a, there is no specific therapy, treatment is support, right? More often, chronic hypervitaminosis is seen many times. People keep consuming self-medication, thinking vitamin A is good for the typical scenario will be a child or a person gets specs. And it's a common, misconception that if we take long-term high-dose vitamin A, the specs will come off without consulting a doctor. They will take, and that is one of the common scenario. So, in an Indian setting, which type of vitamin A excess is more common? In clinical setting, the chronic type is found to be more common. Right now, since Manmeet asked me about the doses of vitamin A for xerophthalmia, I will write. So let us write. I'm changing it. So if I have to use the doses of vitamin A, so I'm giving the heading doses of vitamin A, the regimes that we use. First of all, what is the route that we are using? Doses for xerophthalmia. The regimes for xerophthalmia. The route will be oral route. How many doses? Number of doses? Number of doses? Sorry, because the screen got stuck. Now it is better. I will have to repeat it again. Can you see the screen or should I share it again? I'm sharing. So, one liner on vitamin A. So, what are the doses that you need to remember? Doses that we need to remember. So, route of giving vitamin A is oral. What is the regime that we use? Two types of regimes are available: 0, 1, 14 days. If that is not possible, we go for 0, 1, 28 days. Both the time of regime. So, both of them are called as the 3-day regimes. So 3-day regimes are used in vitamin A deficiency state. And what is the dose? That will be age dependent. So let's make a chart. On one side age, other side each oral megadose. Each oral megadose. So if the age of the patient is less than 6 months, each oral megadose will be 50,000 international unit. If it is 6 to 11 months, it will be 1 lakh international unit. And if it is equal to or more than 12 months, this is the thing people often ask, sir, exact 12 month ka hai to kya denge? We will give 2 lakh international unit. There is a thing you need to remember. If age of the patient is less than 1 year, if age of the patient is more than 1 year, but weight is less than 8 kg, you will give half the dose. That is, you will be giving 1 lakh international unit. 1 lakh international unit will be given to the patient, right? And in case you are supposed to give oral or parenteral, you are forced to give parenteral forms. What about parenteral doses? So for parenteral doses, you need to remember that if patient has vomiting or malabsorption or sick patient who cannot take orally due to some reason, you can use parenteral form. Not the IV form, the IM forms are the ones which are used. If is less than 6 months, you will be using 75% of the original dose, the dose that we discussed. And if the age of the patient is equal to or more than 6 months, you will be using 50% of the original dose. 50% of the original dose. This is the dosing regime that we follow. Manmeet Singh, yes, corneal ulcer, you can give oral. Oral has been found to be as good as IM. For example, croup patient, oral dexamethasone, IV dexamethasone have equal efficacy. Similarly, even in corneal ulcer, oral as well as IM vitamin A have equal efficacy. But you are forgetting one thing. I told you that corneal ulcer, to save vision, Akela vitamin A is not going to be sufficient. So we give oral or IM vitamin A. Doesn't matter. You have to take ophthalmology consultation. Padding, bandaging, and specific management of corneal ulcer also needs to be done in such patients. Okay. And as a part of whenever you are using prophylaxis, so remember there is also a prophylaxis program we follow now as a part of National Program for Control of Blindness. For part of prophylaxis, government says that all healthy children between the age group of 9 months to 5 years should receive one vitamin A mega dose, age appropriate, obviously, every 6 monthly. Every 6 monthly, right? So first dose कौन कितनी रहेगी? First dose will be 1 lakh international unit, and all subsequent doses will be 2 lakh international unit each. अब इस पे एक बड़ा इंटरेस्टिंग चीज आती है कि व्हाट इज द क्यूमुलेटिव डोज गिवन. Cumulative dose in prophylaxis program. So cumulative dose will be 17 lakh international unit. इसका मतलब क्या? What does it mean? What it means is that how much is the total dose you are going to give as a part of prophylaxis program. So 9 months you give the first dose, that is 1 lakh. Then 6 months later, 2 lakh. 6 months later, 2 lakh. 6 months later, 2 lakh. Keep on adding till 5 years. It will be total 8 doses of 2 lakh international unit. So 8 into 2 is 16. And the first dose, which was given at 9 months, is 1 lakh. So total comes to 17 lakh international unit. Right? So this is also a very interesting way of asking. It is mentioned in the textbooks. So just a matter of time before examiner asks you things related to it. Now, whenever there was a question of vitamin A and chronic vitamin A deficiency, examiner can make a very interesting question. He can say bony pains, alopecia, hepatosplenomegaly, high hypercalcemia, which vitamin excess should be suspected. Now, if you think of bony pain, alopecia, and hypercalcemia, many people will mark hypervitaminosis D. No, the answer is chronic hypervitaminosis A. That should be your answer, right? So this is one thing I wanted to emphasize. So this is regarding. So our time is also over. Already the session is 2 hours long. I was supposed to take it for 1.5 hours, but I've tried to cover a lot of ground, some updates, and a lot of one-liners and some PYQs. 3-4 questions I've shown you as it is, and about 15 to 20 previous year question NEET SS I have also marked in the video. So I hope you benefit from it. LRR 2, it will again be a lengthy session, but now we will be moving into metabolic disorders. I will take up shock. I will take up rheumatology. I will take up vasculitis, and I will take up the remaining vitamins in that LRR number 2. So join me. The dates have already been shared and all this has been shared. Save this video, watch it again. This is going to be useful, and play it in 1.5x once again whenever you are doing something. I hope you benefit from it. So keep preparing. Thank you so much. Rohan Acharya is asking how much number of correct questions are needed for top ranks, correlation with grand test, frequency of GTs. Rohan Acharya, frequency of GT exam is around the corner. Try to give not more than 2 to 3 GTs. 2 to 3 GT should be fine in the remaining days. Second thing, how much number of correct answers? Nobody knows how the paper is going to be, as much as possible, right? There is very little information or data available on NEET SS compared to NEET PG and I9 CT. So that is why as much as possible, papers are becoming more and more clinical. Generally, if you score above 75%, you get the specialty of your choice. And if you are 80% or that range, 80% plus, you get it in a good college. So keep that. That should be the minimum aim that you should be doing. But again, it will differ according to the difficulty level of the exam. Okay. So Chabi Thakur, drug of choice is none. Guidelines clearly say drugs should be used in selected cases and are used in reserved cases. They are not the primary or even secondary line therapy in pediatric obesity. So if you have to still use Orlistat is the one which is preferred. More data is available. Although GLP-1 is safer, but GLP-1 is the data in the children is lacking. If I have to mark, I will mark Orlistat. what is the schedule of Ankita Day schedule will be posted on the super specialty group. I'm not very sure. I've given the dates, but as I said, I'm a bit jet lagged, so my brain is a bit foggy. It will be posted by in the group itself. The team will post in the comments only. Arvind, the Telegram channel name you can search Sandeep Sharma. अब यहाँ पर डाल नहीं सकते यार. I'm forgetting my own name. Pediatric SS and Residency course by Sandeep Sharma. Yellow color. I'm wearing something, and you will get it right. Otherwise, you can drop me a message on social media. I will forward it to you. Should we go through revision videos or revised notes? Manmeet Singh, your own notes revision is the most important thing. If you get time, attend these sessions. Whatever extra points you feel, add them to the notes. But no video, no revision program can be a replacement for your own notes and preparation. That is the primary thing. Okay. A list of important topics, Sudhindra Lakshman, I will be posting in the next session. I will share. Okay. Thank you so much. And we meet again. The days will be announced soon. In the next, I think 3 or 4 days, 4 or 5 days, I will be coming in. And the next 2 sessions will be consecutive session. So 2 दिन लगातार होगा. So 2 hours, 2 hours. So another 4 hours of session is coming for you, and 1 session will be close to the exam. Right? Thank you so much. Good night, everyone.